What exactly is Clomid? Everything you need to know about clomiphene citrate. Hello, friends. I'm Dr. Emma Mary, and I work as a fertility specialist. I find myself talking about Clomid almost every single day in my practice. I receive so many questions about this medication, and today I want to take just a few minutes to walk you through what Clomid actually is, how it functions inside your body when we decide to use it, and what side effects or important points you should be aware of so that you can feel as informed and empowered as possible. Now, Clomid was originally developed and used as an ovulation induction agent. That means its primary job is to help you ovulate. Over time, we have expanded that use to include some people who actually do ovulate on their own, and I will explain that situation as well. Interestingly enough, Clomid also has some applications for men. So what is Clomid really? Clomid belongs to a class of medications called a SERM, which stands for Selective Estrogen Receptor Modulator. The way I want you to picture this is that Clomid comes into your body and binds to estrogen receptors. By doing so, it tricks your body into thinking there is no estrogen present. Let's use your brain as the reference point. Here's what normally happens when you ovulate. Remember that every single month, a group of eggs comes out of that vault inside your ovary. Each one of those eggs produces a tiny amount of estrogen, but not nearly as much as your body ultimately needs. This small amount of estrogen sends a signal to your brain saying, "Hey, we need to ovulate." In response, your brain sends out FSH, which stands for follicle-stimulating hormone. FSH is very well named because each egg grows inside its own follicle. As FSH rises, one egg will begin to grow. As that egg matures, it starts making much more estrogen. That high estrogen level will eventually peak when you have a fully mature egg, and that peak acts as the trigger for your brain to send out an LH surge, which then allows you to ovulate. So what goes wrong in people who don't ovulate or don't ovulate well? In many cases, the body may not be sending out enough FSH. Part of the reason for this can be that the estrogen signal is too high. When estrogen is already elevated, your brain cannot properly interpret that it needs to release more FSH. This can happen for a number of different reasons. Some people have a naturally high baseline estrogen level. Others have a high follicle count. Because if you have a lot of eggs inside that vault, more will come out each month, and that leads to a higher baseline estrogen level. Being overweight can also play a role because fat cells themselves can produce estrogen. So there are many different reasons why that brain-ovary signal might get misinterpreted. You end up stuck in a situation where your brain isn't sending out a strong enough FSH signal, but it doesn't realize anything is wrong because the estrogen level is already high enough, so you just remain trapped in an anovulatory pattern. A perfect example of when we see this is PCOS. That's exactly what happens. The ovary gets bored from lack of proper signaling, and it starts making testosterone instead. Why? Because LH from the brain starts stimulating certain cells in the ovary to produce testosterone. That leads to some of the secondary characteristics of PCOS, like acne, hair growth, weight gain, insulin resistance, and so on. But if we want to come back and reverse this process at the ovary level, the root of some PCOS problems is really that you're not ovulating. That said, people who don't have PCOS can also get stuck in an anovulatory pattern. This is where Clomid comes in. Clomid will bind to those receptors in your brain. Suddenly, instead of sensing a high baseline of estrogen, your brain thinks it has none at all. In response, it sends out a strong surge or signal of FSH. Hopefully, that signal is strong enough to get one egg to start growing. Now, you only take Clomid for 5 days. Why? Because naturally, you're only supposed to have a temporary rise in FSH. You don't need continued high levels of FSH because your body requires the brain and ovary to be able to communicate properly. We don't want 8, 10, or 20 eggs to grow. We want that FSH level to drop as your estrogen rises so that only one egg continues to develop. That is the natural feedback mechanism that prevents humans from having high-order multiples. The truth is, a lot of this process depends on your brain's interpretation. The lowest dose of Clomid is 50 milligrams. That's one pill. You can go up to 2 pills a day, which is 100 milligrams. 3 pills a day is 150 milligrams. Those are the studied doses. Some of us will even go up to 4 pills a day, or 200 milligrams, in someone who might be refractory or not responding to lower doses. Sometimes you can stair-step patients up, try a dose, see if they respond, and if not, go up. Some patients have what I call an all or none response. I tend to see this more in patients who have a high AMH. They will either over-respond dramatically or not respond at all, and this is actually one reason why some people have to move on to IVF, because in IVF, I am giving you FSH directly. I am not relying on your brain to interpret anything. And in that setting, I am perfectly fine with many eggs growing, because I can then take those eggs out of your body, fertilize them to create multiple embryos, and selectively put just one back in. But when you are ovulating naturally, I have to be very mindful of high-order multiples. That's really where a lot of those reality TV shows come from. Not from IVF, but from ovulation induction, where people ovulate numerous follicles at one time. Clomid was the original ovulation induction medication, and it has been around for a very long time. Importantly, it is no longer the standard of care for PCOS. That doesn't mean we never try it in some PCOS patients. But in PCOS, studies have shown that Letrozole, which is also called Femara, they are the same medication, is actually the standard. However, some patients won't respond to Letrozole, and in those cases, we may try Clomid. It has been used for people with PCOS for a very long time. Clomid also will not work if you have hypothalamic amenorrhea. If you're not ovulating because your brain is not sending out any FSH at all, then you already have low estrogen levels. Your brain isn't doing anything. So coming in and binding your estrogen receptors so that your brain senses even lower estrogen is not going to change the outcome. That's why understanding what is behind your anovulation is extremely important. Maybe it's PCOS, maybe it's hypothalamic, maybe we don't know yet. But at least ruling out hypothalamic amenorrhea is going to be a key part of this process. Because Clomid binds to these receptors in your brain, you may experience some symptoms. Some people have none at all. But other people can have some pretty severe symptoms. These symptoms essentially feel like menopause because your body is freaking out. It doesn't just think you have low estrogen, it thinks you have no estrogen at all. So hot flashes, insomnia, mood changes, irritability, those are some of the most common symptoms. You may also feel emotional, lethargic, or have difficulty sleeping overall. This is not necessarily pleasant, but it is short-acting. Once your body starts growing that follicle, it will make estrogen, and those symptoms will go away. Clomid, because it is a SERM, also impacts other places in your body where estrogen receptors are present. One notable area is the uterus. Inside your uterus, you have estrogen receptors as well. So one adverse consequence of Clomid can be a thin endometrial lining. That's why I personally like doing ultrasounds when I have patients on ovulation induction. So I can see how their lining looks. Not all doctors do that. But if you've noticed that you took Clomid and your period was lighter than normal or much lighter than usual, that might be concerning. That would be an indication to try Letrozole or something else, because you do need a lining that is appropriate for implantation. Another thing Clomid can do is cause persistent cysts. These follicles grow, and you are ovulating more than with other ovulation induction agents. Some people develop ovarian cysts after using Clomid. These cysts aren't usually harmful, but they can delay your treatment. You might have to wait for them to heal before you can do another cycle. And remember, anytime you are growing a follicle or you have a large ovary, you do have a risk for ovarian torsion. That's when the ovary twists on itself. It can be very painful, it is a surgical emergency, and you could potentially lose that ovary. So we take that risk very seriously. Also with Clomid, there is a very, very small risk, based on how estrogen interacts with blood vessels, of a stroke. I know that always sounds really scary. Remember, estrogen does put some people at risk for blood clots and stroke, but the warning sign here is vision changes. Although headaches can be common when you have low estrogen, you should not have vision changes. If you do, you should tell your doctor immediately and not use Clomid again. So, what are the biggest real risks with Clomid? The major real-world risk is multiple pregnancy. About 5 to 8% of people using Clomid for ovulation induction will have multiples. That is what we are most concerned about. Most twins do just fine. Not all twins, but most. But we really don't want to see those high-order multiples like triplets or more. The higher the dose you take, the higher your risk becomes. The other major risk is simply not responding, whether it's hypothalamic amenorrhea or refractory PCOS. Not everybody will respond to all ovulation induction agents. This is why, in some studies or based on your specific clinical scenario, your doctor might say you should also use metformin. Metformin can lower some of your testosterone and improve insulin resistance, and that might help Clomid work better. Or you might need to use steroids, or you might need to try to lose a little bit of weight. If you have tried the maximum dose of these medications and it's still not working, then other options need to be considered. Now, Clomid is not my favorite option for PCOS. I like to try Letrozole first. So when do I use Clomid? It is my drink of choice for anybody who has unexplained infertility and we are trying to super ovulate them. Remember that for unexplained infertility, you have two main treatment choices. One is IVF, the other is super ovulation plus an IUI. In that super ovulation group, I am purposefully trying to get you to ovulate more than one egg, and then we do an insemination. I really like Clomid for that scenario. I am typically shooting for between 2 to 4 eggs. That really depends on your age. If you are older, I will tolerate more eggs than if you are younger. I also like Clomid for luteal phase issues. If you do ovulate, or you feel like your luteal phase is too short, or you're spotting during your luteal phase, I really love a low dose of Clomid. I feel like it normalizes that phase nicely for most people. Also, if you have very low ovarian reserve but you're not ovulating well, which sometimes we see as that AMH drops, that is another situation where I prefer Clomid over Letrozole. Some people use Letrozole first line because you tend to have a less abrupt response, maybe a lower chance of multiples, and really fewer side effects. But I think about it this way. If you have PCOS, I'm going to try Letrozole first. If you have some of these other indications, unexplained infertility, low ovarian reserve, luteal phase defects, I will probably try Clomid first. Clomid can also be used in IVF cycles. At the beginning of an IVF cycle, you might see a burst of Clomid, and you might ask, why am I using that? The reason we use it then is exactly the same way. It's a complete block of the brain, and you will get the brain to send out all the FSH you have. Remember that in IVF, you are using FSH as an injectable hormone. If I can get away with a few days of using what your brain is giving me for free, that's fantastic. This is not good for an average IVF patient because you probably need more FSH than that. But if you are in one of two groups, very low ovarian reserve, where I don't need much FSH because you don't have many follicles, Clomid can be a great option. Or if you have very high ovarian reserve and I am trying not to get all your eggs to grow, so you have a combination of PCOS and hypothalamic issues, and I'm worried about ovarian hyperstimulation syndrome, I might try to come in with something like Clomid to start things off a little slower, purposefully not recruiting all your eggs at once. Another situation where people use Clomid is for men. In the same way, blocking estrogen receptors and getting the brain to send out more FSH can help men who have low testosterone or a low concentration of sperm. It does have some of the same side effects in men: headaches, irritability, emotional changes, things like that. And it is used differently. Typically, it's half a pill every single day. So, unlike for ovulation or super ovulation, where we do a 5-day burst, in men this is a constant daily medication. So, Clomid is a medication that has been around for a very, very long time. Overall, it is extremely safe. It is not associated with birth defects. It is not associated with cancer or other adverse outcomes. Our biggest risks are truly going to be either multiples or not responding. And then the side effects are really what make it intolerable for some people. But again, some people have zero side effects at all. So if your doctor wants to try Clomid, just make sure you understand how it works and what you are looking out for. And if you have PCOS, using Clomid is not wrong, but using Letrozole might be something you want to consider. All right, guys. Thank you so much. If you have questions about Clomid, put them in the comments. We will keep doing educational videos because I am here to help you learn about your body. As always, thanks my beloved friends for watching these videos.